So this talk will address the clinical problem of a combined ACL and medial complex injury with a special emphasis on the negative effect of hamstring harvesting and the positive role of posteromedial stabilization. I will start my talk with the role of posteromedial stabilization. As you will see during my talk, I have a bit of a problem with the term posteromedial stabilization in the context of an ACL injury. In general, the incidence of MCL injuries in knees with an ACL injury is high and probably higher as previously thought. In this study, the group around Andy Williams retrospectively analyzed the MRIs of 100 professional athletes with presumed isolated ACL injuries and found an incidence of MCL complex injuries in 67%. The SMCL was injured in 62% and the DMCL in 31% and the POL in 11%. From a biomechanical point of view, valgus laxity caused by MCL deficiency may increase strain on the ACL and may therefore jeopardize ACL graft survival. This is an older biomechanical study from 1991 in which the authors could demonstrate that a section of the MCL dramatically increased the force generated in the ACL when valgus moment or external rotation of the tibia was applied. The authors therefore concluded that an individual who has residual valgus laxity as a result of a previous injury of the MCL may be at increased risk for potentially injurious forces generated in the ACL. This conclusion is also supported by more recent biomechanical studies. In this study, the role of the MCL on ACL strain was evaluated during simulated landing. ACL strain was measured with the MCL intact, transected and reconstructed. The main finding was that during valgus landing, a knee with an incompetent MCL puts the ACL under increased strain and hence also an ACL graft. Another finding was that this increased strain may be reduced to baseline levels with MCL reconstruction. So from a biomechanical point of view, medial stabilization seems to have a positive role. The positive role of medial stabilization has also been demonstrated in this biomechanical study. The authors found that in combined ACL and SMCL injuries, single bundle ACL reconstruction could not restore anterior valgus and rotational laxity, and SMCL reconstruction was also required. The conclusion of this paper was therefore that with combined ACL and severe SMCL injury, both ligaments should be reconstruction. So, taking these biomechanical studies together, there seems to be a positive role of posteromedial stabilization in combined ACL and MCL injuries. Let's move on to the clinical evidence. This is a study based on the Swedish National Ligament Registry, in which the outcome of patients with an isolated ACL tear were compared to patients with a concomitant medial ligament injury, which was either treated non-surgically or surgically with either suture repair or reconstruction. And in this study, it could clearly be demonstrated that non-surgical treatment of concomitant MCL injury in the setting of an ACL reconstruction may increase the risk of ACL revision. The same observation has been made in patients undergoing revision ACL reconstruction. In this study from the group of Karl-Heinz Frosch from Germany, Hamburg, on 111 patients undergoing revision ACL reconstruction, patients with preoperative medial knee instability had a 17-fold increased risk for failure. However, the clinical evidence on the role of medial laxity and medial stabilization is conflicting. This is a prospective randomized controlled trial which included 47 patients with acute combined ACL and grade 3 MCL injuries. Treatment of the MCL injury was randomized into two groups. In one group, early ACL reconstruction was combined with MCL repair, and in the other group, early ACL reconstruction was combined with non-operative treatment of the MCL. Clinical evaluation after 2 years included KT1000 measurements, telos valgus radiography, functional tests and clinical stores, and what the authors found was no significant difference in any outcome measures. This high-level study therefore suggests that there is no need to address the MCL even in grade 3 injuries if early ACL reconstruction is performed. Me personally, I think that this study must be interpreted with care, since I believe that the classification of a grade 3 injury does not provide enough information to define the best treatment. A grade 3 laxity can be the result of very different injury patterns, whereas this proximally located tear on the left may be able to heal well. I do not believe that a mid-substance tear with a flipped proximal end, as you can see in the middle, or a completely dislocated distal avulsion, as you can see on the right, will heal sufficiently. I therefore believe that the indication to surgically repair the MCL should be more individualized based on this specific injury pattern. Interesting studies have also been published by the colleagues from Rizzoli on the treatment of ACL and grade 2 MCL injuries. They have published 3 different studies, but all of them include the same patient cohort. This cohort consisted of 57 patients. 37 patients had an isolated ACL tear and 20 patients had a concomitant grade 2 MCL tear. A grade 2 MCL tear was defined as IKDC grade B or C, which includes medial joint opening from 3 to 10 millimeters. The time from injury to surgery was more than 3 months, so the injuries can be regarded as chronic, and an isolated double bundle ACL reconstruction was performed in all patients without addressing the medial instability. In the first of the 3 studies, navigated kinematic evaluation was performed before and after ACL reconstruction, and they found greater AP and varus valgus laxity and in the ACL and MCL group post-operatively. Altogether, differences were small, with approximately 1 degree more varus valgus laxity and 1.3 millimeter more AP laxity. Nevertheless, the authors discussed that this residual laxity may have a negative effect on the future clinical outcome and graft survival. For this reason, the clinical outcome and instrumented laxity measurement was evaluated after a minimum follow-up of 3 years in the same cohort. The main findings were a significant greater medial joint opening in combined injuries, but no significant difference in AP laxity and no significant difference in clinical outcome. Based on this study, residual medial laxity may therefore have a neglectable impact on clinical outcome, at least in the short term. And only recently, the long-term results of this patient cohort was published with a 14-year follow-up, and again, there were no significant differences in clinical outcome or failure rate between both groups. Taking the results of these 3 studies together, the role of medial stabilization in grade 2 injuries seems to be questionable. Other authors, however, have presented different results. In this prospective study, 112 patients with a combined ACL and grade 2 MCL laxity with a so-called floating meniscus sign were included. Surgery was performed between 3 and 6 weeks, and treatment was randomized to either ACL reconstruction combined with MCL reconstruction or ACL reconstruction and non-surgical MCL treatment. The floating meniscus sign is defined as abnormal positioning of the medial meniscus with opening of the medial compartment and is a sign for involvement of the DMCL. After 2 years, the author found significantly better results after MCL reconstruction compared to non-operative treatment of the MCL, with less ACL reconstruction failure, less residual MCL laxity, higher Tigner score and higher Lysholm score. Therefore, in patients with grade 2 laxity and involvement of the DMCL, medial stabilizations seems to be of advantage. With regard to current reconstruction techniques, the most common ones focus on reconstruction of the MCL and most also on the POL and are therefore considered posterior medial procedures. However, I question if we really need a posterior medial stabilization. Cause the main clinical problem we are facing with is anteromedial rotatory laxity, which is characterized by increased valgus motion but also increased external rotation of the tibia, leading to anterior subluxation of the anteromedial tibial plateau. And if we look at the structures relevant in controlling anteromedial rotatory laxity, the POL is not of importance. The ACL is of course the primary restraint against anterior translation. The SMCL is the primary restraint against valgus load and for external tibial rotation. The DMCL is the primary restraint near extension, and the SMCL was dominant in 60 and 90 degrees of flexion. Therefore, the deep MCL rather than the POL seems to be relevant with regard to reconstruction techniques. And if you look on this nice picture on the right here, you can see the DMCL oriented anterodistally across the joint line, and it may remind you to the ALL on the lateral side, and we should probably call it the AML. My personal techniques in patients with anteromedial rotatory laxity aims to reconstruct both the DMCL and the SMCL. It involves 2 tibial tunnels and 1 femoral tunnel. The free ends of the graft are fixed in the tibial tunnels, and the loop of the graft is passed superficial to the MCL and fixed in the femoral tunnel. What I have changed recently is that I place my tibial DMCL tunnel more anterior to get a more anterodistal course of the DMCL. This technique has been evaluated biomechanically and was able to restore native knee external rotation, and the authors called this technique an anteromedial reconstruction. My indications for anteromedial reconstructions are ACL insufficiency with concomitant grade 2 and 3 valgus laxity, a positive Slocum test finding in which external rotation fails to eliminate a positive anterior draw test result, and a positive dial test finding caused by anterior translation of the medial tibia rather than posterior translation of the lateral tibia from posterior lateral rotatory laxity. The other aspect I was asked to talk about was the effect of hamstring harvesting in patients with combined MCL and ACL injuries. So why is this important? Well, if we have a look on the function of the medial hamstrings, we see that they not only have a synergistic effect with the ACL, but also with the MCL. In full extension, the tendons run parallel to the MCL, and in knee flexion, the medial hamstrings evoke an active posterior tibial translation with internal rotation, or in other words, the medial hamstrings are active stabilizer against anteromedial rotational laxity. This effect has been demonstrated in biomechanical studies. In this study, the joint stabilization effects of the hamstring muscles in case of MCL insufficiency was analyzed, and the authors found that semitendinosus and gracilis muscle load minimize valgus instability in MCL insufficient knees near extension. This is another biomechanical study on the effect of hamstring harvest on knee stability in the setting of ACL injury, and ACL reconstruction in knees with a partial MCL injury. And the results showed that after ACL reconstruction in knees with a partial MCL injury, simulated semitendinosus and gracilis harvest did not alter anterior stability, but led to increased valgus motion. So both based on these biomechanical studies, the medial hamstrings are dynamic medial stabilizers, which might protect the ACL graft and healing of the MCL in combined injuries. Whether a hamstring sparing approach is of clinical importance has not yet been studied intensively. The only study I am aware of is this one based on the Swedish National Knee Ligament Registry. The authors compared the risk of ACL revision and PROMs after ACL reconstruction with a concomitant non-surgically treated MCL injury with regard to 3 ACL graft choices, namely semitendinosus and gracilis, and patellar tendon. These are the results. Risk of ACL revision did not differ between groups. Altogether, there was no indication that the use of hamstring would lead to inferior outcomes compared to BTB. A secondary finding was that independent of graft choice, the majority of patients failed to achieve an acceptable symptom state at both the 1 and 2 year follow-ups in most KOOS subscales. Or in other words, patients with a concomitant non-surgically MCL injury did not well. This finding emphasizes the need for further improvement of diagnostics, indications and surgical techniques for medial stabilization. So, in conclusion, MCL deficiency may increase the risk of ACL revision. Indications for surgical treatment of acute MCL injuries are controversial, and treatment recommendation based on grades and laxity are insufficient. Even less evidence exists for the treatment of chronic MCL injuries, but involvement of the DMCL seems to play an important role. You should consider an anteromedial rather than a posterior-medial stabilization in patients with anteromedial rotatory laxity, and biomechanically hamstring sparing seems to be beneficial, although clinical evidence is still lacking. Thank you very much for your attention.